Thanks everyone for joining us this evening. Appreciate the time that you've taken out to really talk about this important but really less discussed topic in a healthcare world. And I think that is characteristic of healthcare systems worldwide. So I'm going to spend the next sort of 30-ish minutes, 30, 35, 40 minutes talking about what is really patient and family stories, and providing you with a couple of examples that Bisma, myself, and others on our team have been working on to really leveraging those patient family stories for healthcare improvement and healthcare research. And we'll have time for question and answer, of course, at the very end if we want to have that discussion. But first, I just wanted to just introduce myself a little bit more. So, I usually call myself a research methodologist because that's where I sort of started learning about the ins and outs of how to do research. But when I was learning about randomized controlled trials, observational studies, something for me kept on missing, and that was the human aspect of healthcare. And since then, I've been trying to figure out how do we really humanize healthcare, and TMT Corp, as well as some of the other things that we've been working on, is really trying to get that human aspect. But I'm also, my specialty is also patient and family engagement, and particularly in strategic planning of hospitals. So I've worked with many hospitals at this point, particularly trying to understand how patient family engagement fits within both organizational goals as well as organizational practices and strategies on the ground. Yeah, so that's me. Let's get into the context of today. So, the context of healthcare today, when I was thinking about this, I was like, the topic of mine are healthcare systems really, our medical systems really failing, and why are they failing? And this meme came across my WhatsApp conversations, and I don't necessarily, I don't know how I feel about this meme, but it rings some truths and some discomforts. In the UK, I need stitches. Your appointment is in 43 months. In the US, your bill is 60,000. And in Canada, have you considered dying? Now, the Canada version where we're located, I feel a little uncomfortable about that. But as you'll know, and I'll talk about in the example of a narrative inquiry that I conducted last year, this actually came up for a lot of patients who were undergoing were dealing with conditions that they thought they could fix through medication or treatment, but the answer from the providers was medical assistance in dying. We'll get into that, but this is an interesting meme to really start our conversation about the healthcare system today. But some other facts, I guess, just getting to the stats is, and I picked three stats here looking at those three countries, but I'm sure there's stats for all countries on all healthcare systems around the world. But in Ontario, Canada, where we're located, there's about 15, 16 million people here, and about 15% of them now don't have a primary care physician. If you don't know that, primary care is having a real crisis with primary care physicians leaving regular on droves, and residents not choosing primary care for their career. In US, I've known about this fact for a while. It's kind of astonished me. The 220 billion in medical debt amongst US citizens, and I know that has decreased quite a bit since Biden has become president. And in UK, 71% of UK citizens are not satisfied with the NHS, and the NHS is also going through a lot of challenges with the physicians striking because of underpay, with a lack of coordination and case management with other services, and the NHS historically being great system, at least in comparative health systems, we've always been like, okay, what is NHS doing? Now it's really, really struggling, and we're trying to see what the next few years hold for all these systems, but particularly for the NHS. So putting all those contexts, and the reason why I mentioned that is I think the argument I want to make, and I think probably some of you, if not all of you, agree to this argument to some degree, is patient and family stories have a real role to play in addressing some of these very emerging challenges, and maybe even prevent some of the effects of failing medical systems that we see right in front of us. Today's learning outcomes is to talk about patient family stories and to explore the use of those stories in healthcare improvement and healthcare research as well, and to reflect upon some examples developing and using stories. And I'll talk about two examples of the work that we have conducted at TMT and at the University of Toronto. The first part is really stories and stories. I'm going to take this first part outside of healthcare because I think we can learn a lot from other disciplines and industries about what stories and storytelling is. And then I'm going to try to bring it back into healthcare and see what it actually means for us. So when I think about stories, I think about this book. It's Robert McKee's book, Story, Substance, Structure, Style, and the Principles of Screenwriting. This is the first book that came to mind when I was like, okay, how do I really define a story that's not from healthcare for all of you? So Robert McKee defines it as story is about principles, not rules. A story is a narrative, either true or fictitious, in prose or verse, designed to interest, amuse, or instruct the hearer or reader. It is a fictional or non-fictional narrative that is intended to convey a series of events which together narrate a tale. As you can see, the definition of story is interesting, but definitely from a particular area of screenwriting. And that's sort of my comment at the very bottom is that, it's a good definition, but I'm kind of thinking of something different and something a bit more transformational because that's what we need in healthcare. So what am I thinking in terms of a transformational definition? So what I really did was, I've looked at definitions of storytelling and knowledge mobilization articles or implementation science articles. And I've looked at other narrative inquiry studies where they talk about stories and storytelling, and I don't think there's a compelling enough definition, at least for me. There's some definitions that are helpful, but not a compelling enough definition. And maybe that means that we need to do a little bit more work defining stories in healthcare improvement and research. But one possible definition here that I sort of made up that's helped me understand and really ground my work is the strategic use of narratives to share experiences, challenges, and successes within the healthcare setting with the aim of illuminating complex issues, fostering empathy, and driving meaningful change. Again, in this definition, there is a focus on change, on transformation. And then the obvious question here is, this always comes in my conversations with administration, management, where I work with regularly and talk about patient family stories. It's always why. Why do we really need this? Why do we need to spend some time talking about patient family stories? We have the outcomes, we have the economic data. Let's just do it, right? And these are just some benefits or some reasons why we need patient family stories to bridge the gap between medical care and experience, to really humanize care, to enhance communication, empathy, to provide context to support evidence-based practices. Just mentioning that a little bit, I think evidence-based practices is pretty much the go-to formula, you would say, for healthcare today. The problem is the evidence-based care and practices derives from randomized controlled trials that are often a very, very specific context. When it goes out into the real world, into patients, into their lifestyles, social determinants come into play, racialized and racialization come into play, vulnerable communities and their lifestyles come into play, and sometimes those randomized control trials that show efficacy don't really show efficacy or effectiveness in the real world. I think that context is super important to get for evidence-based practices for that reason. Other benefits of stories, humanizing clinical data, tailoring care to individual needs, right? And that's sort of what we focus on, is really designing people-centered services, empowering patients and families, and that gets at the patient-family engagement piece, driving policy change and healthcare reform, and improving those indicators that all hospital systems, at least in North America and Western countries, have now: patient engagement, patient experience, PROMs and PREMs, and patient satisfaction. So those are just some quick definitions. I didn't want to spend too much time there because I think there are a lot of articles out there, which I've included in a resource that I'll send to each of you, that you can further read and further sort of formulate some sort of understanding of storytelling and stories in healthcare. But I did want to mention that to ground our discussion on the applications. And this applications, like I mentioned earlier, I want to talk about two examples and two very different examples on how we at TMT Corp have try to understand, identify, and leverage patient family stories for both change at the policy level and change at the organizational level. So I'll start with the more, I guess, in some ways, a more simpler example. And that's on offloading devices for diabetic neuropathic foot ulcers. The context here is that essentially a government agency is thinking, this is in the past, was thinking of including offloading devices in Canada, and this is a federal sort of government decision-making body, in the public funding mandate. So recommend provinces and territories to include offloading devices in the public funding plan, so it's publicly insured for all citizens. Diabetic neuropathic foot ulcers, essentially offloading devices are kind of like a sole, right? What happens is that diabetes is a lot of pressure gets exerted downwards, which ends up causing ulcers over time, unless there is an opposing force that pushes it up. And offloading devices have shown to be extremely effective in really reducing that pressure and thereby reducing the occurrence of foot ulcers and improving quality of life experience and all those things. So small technology or treatment or whatever you want to call it can have a huge impact. The recommendation or the decision-making process involves a series of evidence indices, and this is one of them, rapid evidence indices. And they wanted to pair the clinical effectiveness data they have with the economic data that they have on how much money they will save in the healthcare system if they choose to fund this on the public funding mandate with patient family experience data that we sort of generated. So this was really trying to understand the patient family experience with offloading devices to provide that context, that humanization of the clinical data that they already had. Just a quick note on the method. So it was an evidence synthesis of 12 studies. It was a rapid qualitative review. That's what sort of they call it, and that's what we call it, just focusing on qualitative studies and doing a very quick and surface level, in some ways, thematic analysis of patient family experiences. And I guess to give you an example, I mean, you can of course read the full report, which is available online, but to give you an example of how these patient family experiences and stories inform the decision making. So this is an excerpt taken from the report. I'll just read it out loud. So long-term adherence to offloading devices was highly dependent on, quote, personal regulating values. These values are individually constructed and include things like self-image, everyday function, environment, and activity risk, and pivotal events that increase their perceived susceptibility of ulceration. Patients are more willing to accept offloading devices that offer greater function and participation in everyday life, contributing to stronger adherence. Personal acceptance also depends on whether the offloading device is aligned with patient's self-image and visual appearance preferences. However, patients require time to incorporate offloading devices into their self-image, which involves rationalizing its functional benefit and changing their lifestyle as a result. So you can see just from this one paragraph, do you really feel that you have a better idea of how some diabetic patients with foot ulcers might use or understand offloading devices? I think by just understanding some of these characteristics, or even just reading it as a healthcare provider or administrator or a policymaker, you can get a better understanding of how patients see these devices and how they intend to use them. And as for a healthcare provider, they may even be prompted to, when they speak to a patient with diabetic foot ulcers, to start considering some of these personal regulating values. So this was sort of the first example in a low effort way, at least compared to the next example, to really understand patient family stories. This rapid review was produced from start to finish within 5 weeks. That's usually the kind of timelines that we work with government agencies who really need rapid feedback and evidence to support their decision making. But it's important to know that this type of rapid review is crucial as among one of the first steps to better understand a research topic and to really focus further efforts to understand how to use patient family stories in healthcare. So for example, there's another rapid review that's conducted several years ago on opioid agonist treatments. And this was when the opioid epidemic was really at its height. and the Canadian federal government wanted to know what to do for their publicly funded opioid agonist treatment, what things to change with them to ensure that they better meet the needs and challenges of patients. So did the rapid review in about 5 weeks. And since then, it's led to a research program both at the Sinai Health System in Toronto, Ontario, as well as the Humber River Hospital on opioid agonist treatments. And currently, I think this rapid review was done in 2018 or something like this, or before the pandemic. But currently, we're about 4 years in, and we're in our 8th research project that started from that rapid review. And the reason why I say this as an example is to emphasize that rapid review might seem like a small task, but it can really set the path forward, chart your path to developing a research program that can last for years and really help you understand what tools and methodologies you need to use to fully, properly, meaningfully, appropriately leverage patient and family stories in healthcare. The second example is the more complicated example, and this is about veterans in chronic pain. So just as a background, veterans, if you don't know of, are much more likely to experience chronic pain, and chronic pain is essentially persistent pain that lasts more than 3 months. And I think the prevalence of chronic pain could be between 30 to 70%, depending upon the region that you're looking at. I mean, like compared to UK, Australia, the US, and Canada. But I think the key factor here is depending upon the system, and of course we're focused on Canada, but some of this applies to the US system as well and other systems too. When military personnel transition from their military life, the military health system, to civilian life and civilian health system, lots of changes happen that are not just limited to going out of military service. Oftentimes they have to change healthcare provider. Oftentimes they have to reconnect with civilian life, social life. Oftentimes they're disconnected to their unit, which they build very strong bonds with when they're in service. And all these changes make that transition period very, very crucial in understanding how they manage, cope with their chronic pain. So this was actually started as a government-funded research project that we at TMT Corp did, and that started as a qualitative evidence synthesis of, I don't remember the exact number of studies at this point, should say on the infographic on the left, but somewhere around 25 studies. And the purpose of that was to understand both the experiences of military personnel during service, during the transition, and in civilian life when they deal with chronic pain, but also use those experiences to develop a research program. So you see at the very bottom here, these are sort of research opportunities. So we developed a research opportunities matrix because the organization that funded us was a research funding organization, and they wanted to use patient family stories to develop a patient-centered, a veteran-centered funding approach to really use their patients, their experiences to understand what priorities they need to fund for research moving forward. That project is done. We completed it last year, but that actually led to a series of other submissions and projects that we're leading right now, one of which is the example that I'm going to give you. And that is looking at identity transformation from military service to civilian life. So all that context and really sharing that with you to really talk about this project here. So this is a narrative inquiry study. And the purpose of this is to chart the stories of military personnel during their service, during their transition to civilian life, and during their civilian life. To divide it up into quote unquote those 3 different stages and to understand how they're managing chronic pain and mental health if they have mental health issues throughout each of those stages, and use that information to understand how their military identity transforms, changes, if at all, throughout this process. So you can see there's so many different layers of this particular project. So this is a government-sponsored study, about $200K that they dedicated to this narrative study over the next year and a half. And the purpose is really to explore and explain identity transformation of military and the role of chronic pain and mental health issues. So there are 54, the methodology and some data collection methods. There are 54 interviews with about 20 veterans. And the interviews are split into a few stages. So first interviews, long interviews, about an hour and a half each, maybe sometimes more, maybe split into a few different interviews depending upon the availability of the participant. But it's really to understand their journey across those three stages: during service, during the transition, and after they've left and in civilian life. Then the next stage is to take each transcript and to really analyze that transcript particularly, and to develop what we refer to as a written composite narrative that's really summarizing in the researchers' words what their journey was during service, during transition, and after leaving service in civilian life. Once that narrative composite is developed, we then go back to the same veterans and then we share it with them, and we repeat it verbally to them in that interview at the very beginning, and we get their prompts and their reactions. And the prompts and reactions include a series of different things. Often, I think that the first reaction that they have is very, very important to gauge how they felt about it. Sometimes sometimes the participants have said, "This does not represent my story at all." Or like, "How dare you talk about my story in this way?" Really, taking it a bit personal and really taking it, owning their own story. Others have said that this is amazing. I have never seen my story really develop in this way. It's so great and reflective to see that. So you can see that there's a range of reactions, and that initial reaction can actually tell a lot. But there's also other kinds of reactions that we prompt for, right? Like accuracy, clarity, anything we missed, and any directions or additions you want to make to the story, having read it. Oftentimes, this does lead to a few other changes that doesn't minimize the story, but definitely enhance it in many, many different ways. And as a knowledge mobilization activity, after we're done the second interviews and we have the composite narratives, we're going to pick 5 veterans whose stories are, quote unquote, we're not at the stage yet, but quote unquote, diverse enough, and compelling enough to submit another REB application and develop sort of both long podcast type of series, interviews reflecting the story, but as well as shorts and things like that to really emphasize and use this as a policy and decision making and awareness tool. So the interviews are ongoing and the video development has not started, but our intention is to do that early next year. We are working with Veterans Affairs Canada and also the Chronic Pain Center of Excellence for Canadian Veterans, who is our government sponsor. And alongside the videos, we have a social media engagement plan through some of our products, Healthcare Humanized, which is our YouTube channel, and Echoes in Healthcare, which is our newsletter on patient and family experiences. So these are just some of the knowledge mobilization. I'm just going to spend a couple of minutes just talking about some other things. So TMT Corp, so, Bisma said that we mobilize organizations to design people-centered services using rigorous research and meaningful engagement. We have several sort of products and opportunities for you to continue learning. Of course, we're going to have more workshops like this in the future. We are developing sort of 2 academies that we're calling it. One is an Academy of Research Methodology, really focusing on things like narrative inquiry, grounded theory, quality improvement, qualitative research, things like that. An Academy of Health System Studies, which I think is very, very important for us to consider as our medical systems and healthcare systems are really struggling around the world. We have our YouTube channel called Healthcare Humanized. We just finished a 14-week series on medical assistance in dying. Tomorrow, we're actually starting our new series. We'll spend about 20 weeks talking about discrimination in healthcare. So stay tuned for that. We highly recommend subscribing to our channel. And we also have a newsletter that we recently started, really talking about the importance of stories and storytelling, really building on some of the stuff that we've discussed here. That's called Echoes in Healthcare. In the very near future, we're also going to build and have a podcast series talking about patient and family stories. So stay tuned for that. And that's going to be part of our Echoes in Healthcare. But that's all for me. Thank you for your time this evening. I hope you took something out of our conversation today and appreciate the question that you had. Feel free to email me afterwards. I have all your emails. I'm going to send you an email with a 1-page resource of some story and storytelling resources. You can use that email if you ever want to get in touch with me. But appreciate your time and have a wonderful evening.